So on behalf of Bayer Oncology, I welcome all the doctors, speakers, and the conversation on prostate cancer updates. So today we'll be having two sessions. Our speakers does not require any introduction, but still, our first speaker would be Dr. Shashank Shekhar Das. Sir is the senior consultant medical oncologist partner. So I request Dr. Shashank sir to please share his and start his presentation.
Let me just share
What
my
is it?
slides.
Sure, sir.
Let me just share my slides. Hope my slides are visible and I am audible.
Sir, just can I have just 1 minute, sir?
Yes.
The slides are visible, no? Sir, we are ready, sir. I've shared the slides, sir.
Next slide.
Yes.
This is my disclaimer. So this is the prostate cancer landscape overall. So patient develop localized or locally advanced prostate cancer, though the presentation of localized or locally advanced prostate cancer to a medical oncologist is a very rare scenario. Most of the patient present to us either in an advanced metastatic setting or in a CRPC setting. The localized and locally advanced prostate cancer mainly goes to the radiation oncologist or surgical oncologist. After being treated either surgically or by radiation, they are kept under follow-up when they develop a biochemical recurrence, and they are either metastatic HSPC or primary progressive HSPC. If the patient was on ADT and then patient has developed a progression, then it becomes a CRPC. Then the metastatic CRPC develops into terminal disease. The patient ultimately succumbs. The treatment of metastatic CRPC, the OS, once the patient had developed a metastatic CRPC, the OS improvement have only 2.5 to 4.5 months. So the main treatment goal of prostate cancer management is to delay the development of the CRP's castration resistance. Next slide. So I've already told that operation to delay metastatic CRPC and further improve the outcome. Next slide. So the landmark trial, the Stampede trial, the Stampede control arm, which was with only the ADT, and the treatment with docetaxel, the progression-free survival with the Stampede data. Stampede trial was around 42.1 month with docetaxel compared to only ADT. Next slide. So what we can do much better. Next slide. So prostate radiotherapy in metastatic HSPC, which was first shown in the Stampede trial, and in patient who were less than 4 bone metastasis, the PFS was the improvement in the PFS was around 0.56, while the overall survival improvement was 0.64. In greater than 4 bone mets, there were hardly any improvement in the PFS and the overall survival. Just next slide. Or no, next slide.
Sorry for the disturbance, sir. My screen got locked out, sir. Just a moment, sir. Yes, sir.
Should I share from my side?
Sir, there was some connection issue. Now it's okay, sir. You can.
Okay. So improving the outcome with systemic therapy in the FQ15 trial, the hazard ratio was 0.88. Then we come across the Chartered trial where the docetaxel has shown an improvement with a hazard ratio of 0.72. The STAMPEDE trial, the arm C and arm E, the hazard ratio was 0.81. And the STAMPEDE trial of again hazard ratio of 0.61. The LATITUDE trial where the hazard ratio of 0.66. Then come the enzalutamide, that is the ARCHES, where the hazard ratio was 0.66. The TITAN trial with apalutamide, the hazard ratio was 0.65. So overall, the hazard ratio was around hovering around 0.6 to 0.7. So now we have a wealth of data supporting concomitant therapies. So what do we choose depends upon the patient clinical profile, the patient disease burden, and the patient performance status and the patient clinical status. So currently the treatment which are the standard of care in prostate cancer based on the PIS1 and the Arasen. The PIS1, that is the chemotherapy plus abiraterone, the docetaxel plus abiraterone, and the Arasen, that is the dialutamide plus docetaxel. Next slide. So in Chartered, where docetaxel has been used in metastatic HSPC, the overall survival in high volume disease was the hazard ratio was 0.63, and the improvement in the overall survival was 16.8 months. But in the low volume disease, the addition of docetaxel didn't have any survival benefit with a hazard ratio of 1.04. Next slide. Similarly, in the LATITUDE trial, where the abiraterone in high risk metastatic HSPC, the abiraterone was the first to show that hormone treatment can be effective. However, it is important to understand the treatment journey of the control arm when interpreting this data. So obviously, the control arm had also done well in this LATITUDE. Next slide. And consideration for abiraterone use in metastatic HSPC, because we have to use 5 milligram prednisolone in metastatic HS along with abiraterone. So these are the toxicity of the abiraterone plus prednisolone combination of fluid retention, osteoporosis, cataract, the hepatotoxicity associated with the abiraterone, and the hypertension. Next slide. The next trial is the TITAN trial, which is the apalutamide in metastatic HSPC, that which have shown a significant PFS benefit with a hazard ratio of 0.48 and an overall survival benefit of the hazard ratio of 0.65. In the subgroup analysis, the PFS in the low volume disease was 0.36, while in high volume disease it is 0.53. Next slide. Now coming to the Enzamet data, where enzalutamide is used along with ADT in metastatic HSPC, and it has shown a clinical PFS benefit of, and it showed a clinical PFS benefit of 0.4, the hazard ratio of 0.4, and overall survival benefit of 0.67. If we do a subgroup analysis, In a low volume disease, the p-value, the hazard ratio was 0.43, but in the high volume disease, the hazard ratio is not quite significant, it's 0.8. Next slide. So combining therapies to further improve the outcome. Next slide. So this is the piece 1 study design, which included the metastatic HSPC, and it includes de novo metastatic disease, but it's just so it included the de novo M1 disease, and it has been the disease extent has been subdivided into high and low volume, and the patients were randomized to standard of care group, pooled standard of care group, well, arm A standard of care and arm C standard of care plus radiotherapy, while pooled abiraterone group has standard of care plus abiraterone plus prednisolone, and standard of care plus abiraterone plus prednisolone plus radiotherapy. So the standard of care was ADT or ADT plus docetaxel. But the standard of care in piece 1 was amended to include docetaxel during the trial. Next slide. So in the ADT versus docetaxel plus minus abiraterone population, in the high volume disease, it has shown that the standard of care plus abiraterone had a median PFS benefit of 5.1 versus 3.5. And in the low volume disease, the median has not achieved. This led to a confirmation that in high volume disease, you could improve the outcome by adding abiraterone to docetaxel versus docetaxel alone. In low volume disease, it didn't seem to be as beneficial as the high volume disease. Next slide. Next come the ARASEN study design, which is the dialutamide plus docetaxel versus placebo plus docetaxel. And this is a global randomized double-blind placebo-controlled phase 3 study where around 1,300 patients of metastatic HSPC were taken, and there has been randomized to docetaxel of 6 cycles plus dialutamide of 600 BID plus ADT versus placebo plus ADT along with 6 cycles of docetaxel. The primary endpoint was the overall survival. Next slide. Around 87% of patients had received the dose, completed 6 cycles of docetaxel in this trial. So if we see the overall survival along with the dialutamide group, the overall the median overall survival has not reached, while in the placebo it is around 48.9, and in around after 4 years, the overall survival in the overall survival after 4 years, the survival in the dialutamide group was around 63% versus 50%. And in the high risk patient, the hazard ratio of dialutamide versus placebo was around 0.71, while in low-risk patient, the hazard ratio was 0.62. So benefit seems in all subgroups. Next slide. The key secondary and efficacy endpoint was time to CRPC, and the time to CRPC with the dialutamide. In the dialutamide group, there was 64% risk reduction with a hazard ratio of 0.36. Time to pain progression. In the dialutamide group, there was 21% risk reduction and the hazard ratio was 0.79. Time to first subsequent antineoplastic therapy in the dialutamide group was 61% risk reduction and hazard ratio of 0.39. And time to first skeletal related event was there was 29% risk reduction, the hazard ratio of 0.71 in the dialutamide compared to placebo group. Next slide. So the PSA response and the outcome in the 24, if we see the PSA as if we see the undetectable PSA in the dialutamide plus ADT group in the 24 weeks, undetectable PSA was achieved in around 48%, while in the 36 weeks, it is around 57%. In the 52 weeks, it has further increased to 60%, while at any time, it is around 67.3 versus 28.6% in the placebo group. And the time to PSA progression, was significantly better in the dialutamide plus ADT subgroup, dialutamide plus ADT arm with a hazard ratio of 0.23. And in the overall survival, more than 2/3 of the patient reached below 0.2 PSA level in the overall study. Next slide. And in the high volume HSPC, metastatic HSPC, the around 62.2% patient had achieved undetectable PSA with dialutamide plus ADT versus 25.8. And the time to PSA progression was also significantly delayed in the dialutamide plus ADT subgroup compared to the placebo with a hazard ratio of 0.2. And in patients who were had an undetectable PSA, the overall survival was significantly higher, around the hazard ratio of 0.3. So dialutamide triplet achieved long period of no disease progression and also significant improvement to the overall survival. Next slide. Similarly, in the low volume metastatic HSPC, the 83% patient had achieved undetectable PSA with dialutamide plus ADT plus docetaxel, while 38.4% only has achieved undetectable PSA. The time to PSA progression was significantly increased in the dialutamide plus ADT with docetaxel with a hazard ratio of 0.09. And the overall survival in patient who had undetectable PSA compared to the patient who had a detectable PSA, the hazard ratio was 0.34. Next slide. So deciding between doublet and triplet in metastatic HSPC, the things to consider are whether patient will be able to tolerate and accept docetaxel, and the extent of disease, that is high volume and the high risk, the likelihood of hormone insensitive clones, age and life expectancy hit hard and early because prostate cancer will be the cause of death. Will docetaxel be an obligation in the near future? Much less effective post ARPI progression. Patient need to be informed of the options. Next slide. So thank you. And with this, I end my session. And if there is any question from the audience, I'm happy to take.
Thank you, sir. I don't think there is any questions as of now, but there are options in chat box. So if anyone has any questions, they can type in their chat box, and I can come later on. Thank you, Shashank sir, for your nice presentation, sir.
Thank you, Arnav.
Thank you, sir. So may I now request PM Mahota, sir? Sir, are you there? Yes.
Yeah.
Yes, I'm sharing my slide, sir.
Yeah, please. Can we start?
Yes, sir. Please start, sir.
Mm. Okay. Thank you, Bayer. And I think the previous Dr. Sasanka's presentation is my work simple. I will discuss about the actually lot of our patients are not eligible for chemotherapy. Actually, who the patient prostate cancer, you grow older, prostate cancer, we see more patient with very elderly patient. And they are not very eligible for chemotherapy, lot of comorbidity. They may not be wanting chemotherapy. So they actually, what we want actually ADT and some drug which is the least toxic and effective also. Next slide. So this is the ARANOT trial. Next slide. Next slide.
Yes, sir. Sharing. There is a glitch. Yes. Now it's going. Yes, sir.
Okay, this is actually the unmet need actually, because when they started the trial actually, they did a survey and they found that 25% of the patient in real world still actually they are receiving only ADT. So they did this trial. There was a lot of trials actually of single agent anti-androgens with ADT actually. It's like darolutamide trial, apalutamide trial. Actually, it started with chartered actually docetaxel. Sometimes we use actually this chartered also in high volume disease. you give 6-cycle docetaxel with ADT and you wait for the PSA to increase actually. We actually, the Stampede, they have a different arm actually. And latitude, we know the criteria of high volume, low volume, Stampede, latitude actually. Then there is two trials actually with Enjamet and Archie's actually. Archie's is more of a radiological PFS like design like the Sarah not. And Enjamet actually they had some mixed population docetaxel treated patient also. Titan is like approximate is like this trial of R0 and this again three drug combination. PIS1 or Arasense. If you see the trial design, Arasense is the best, but that is for the sick patient who can take 6-cycle of docetaxel. Next slide. So this is the need actually. I told this is the our patient. You grow older, you develop prostate cancer, you develop a lot of disease actually, and here may not be very docetaxel eligible. And if you talk of the family about docetaxel chemotherapy, they don't agree actually. We don't want in the old days to give chemotherapy. So a lot of comorbidities, you need the best drug combined with ADT, which doesn't increase its side effect. So darolutamide is the one of the best drugs, and this is the R0 trial additive with darolutamide. Next slide. So we know Arasense, we know this is R0 trial we're discussing, and this is actually ADT, and you any form of ADT with darolutamide. So this is without docetaxel. Actually, this is a mainly prostate cancer actually, and they included till PS0 to 2 actually, and they actually the design is actually 2:1 actually design. Little bit sometimes it is criticized because of the 2:1 design, but this is because of statistical. And radiological PFS is the primary endpoint. Actually, this primary endpoint RFS is really this is actually more used in prostate cancer targeted therapy drugs actually, because we have not to wait for long term to see the OS response actually. This is a open label trial and the patient who are progressing on LDT will receive darolutamide. So you will get a matured OS after a long time. So our radiological prayers and PFS was the primary endpoint, and others are actually OS, time to initiation of subsequent therapy, time to CRPC, which is very important, time to CRPC, PSA progression. And we know if somebody have a PSA less than 0.2 nanogram, they do better long term. And what are the patient who will have the PSA less than 0.2 nanogram? And this is open label randomized trial, and those patients, they will go take darolutamide and the OS will actually come later on the mature. Next slide. This is actually well-conducted trial, more of a white in white, more of a this more the Asia, Australia, New Zealand, Europe, and North America, so less patient, Latin America, and more of a India, China actually, Asian countries. So it is actually see the Asian populations were well, they are in the paid trials, it's around 32%. And if you see the ECOG performance actually 50-50, actually somebody 0, mainly 1 to 2 patient. If you see the median PSA was actually high 21.4 actually. And if you see the high volume disease, de novo, we know actually the de novo patient, they do well. If it is a recurrent, they don't do well. But here actually there was 22%, but 23% of the patients were recurrent. So it is well represented trial, and the visceral metastasis was low actually, but prostate cancer going to viscera is less actually. And maximum are actually untreated patient, and there was prior local therapy in 18% of the patient. Next slide. This is the reason actually, after China in Asia countries, India was the second recruiter actually. So a lot of Indian patient in this trial. So actually one patient, where the Indian patient were more actually, there was more of a trial of 61 patient were for India actually. Next slide. So it actually in into less than 2 years, the RFS endpoint was achieved actually. If you see the RFS, it decreased the radiological progression by 46%. It is equivalent to other trials actually. To see the RFS actually, it is equivalent to other trials. So adding either it is apalutamide, enzalutamide, it's equivalent actually, and it is decreasing the radiological PFS to 46%. Next slide. So if you see the benefit actually, older, younger patient, and if somebody has a bad PS, listen score more, disease is high volume, race, and geographic area, visceral metastasis or only bone metastasis, and prior local therapy, you can see the hazard ratio of RF radiological PFS is maintained actually everywhere. So it is actually, if you see the high volume disease also, it is working. Next slide. So the secondary endpoint were actually here the pain progression, time to metastatic castration resistant actually, which is very important, and you can see the other ratio is very good, 0.40. Time to PSA progression is 0.31. So it's a very good drug actually. Time to pen progression. There's a lot of trials that didn't use pen progression. This is the trial which included pen progression. OS actually this, because of the randomization, OS is imaginary better but not statistically significant, and you can know the OS actually at later point of life actually, time. So this is not a mature OS data, but other endpoints of the prostate cancer trials are good or equivalent to the other drugs, which is not a chemotherapy. Next slide. So it delayed the CRPC actually. CRPC very important. You can see the graph. CRPC is very much delayed actually, and hazard ratio is 0.60% decrease in the time to CRPC actually, and pain progression, which is very important patient point of view, and it is increasing the hazard ratio is 0.72. So it is increasing the pain progression and time to CRPC, which is very practical actually. Next slide. So PSA response actually, what we see actually, the patient actually, if somebody have a PSA response very less than 0.2 nanogram, which hardly you will see actually in the clinical other drugs actually. And this is very high actually in this trial actually in the Dalmedan. And time to PSA progression actually is actually very high, 0.31 hazard ratio. So the response is very deep, and the response duration is actually more actually if you darolutamide. So 63% of the patient did have the PSA 0.2 nanogram ml, and there are actually 70% improvement in the time to PSA progression. Next slide. So if you see the both the high volume, low volume disease at the time point actually, more patients are having undetectable PSA. This undetectable PSA is actually less than 0.2, not 0.2, nanogram per ml. So with both in high volume and low volume, more patient having undetectable PSA, and actually their response is very prolonged. Next slide. So more patient actually, this patient progress, you give treatment actually, and more patient in the placebo arm actually they progress fast, and they had a subsequent antineoplastic therapy that is actually more docetaxel, but they've taken other drugs also. Abiraterone and enzalutamide, apalutamide doesn't work well after this drugs actually, but they've taken, but more of a docetaxel, and some they've taken olaparib actually, but more patient in the placebo arm, they've taken the other lines of treatment. Next slide. So the drug toxicity is very important actually. Here actually the ADT toxicity and the toxicity of adding another drug actually. Toxicity, treatment related toxicity was not there in the trial, but there were grade 3, 4 toxicity, which is actually equivalent actually. This darolutamide is not increasing the toxicity of ADT, despite actually they are being used for prolonged period. Next slide. This is the typical toxicities actually. What they occur with ADT actually, and you can see the toxicity they are not increased in the darolutamide. And the problem of our patient, if you want used like drugs like enzalutamide, they complain of fatigue, and here the fatigue actually is less actually darolutamide. And second is a little bit more fracture risk actually in darolutamide arm. Otherwise, fatigue is very less actually. Next slide. This is the this is the typical toxicities of ADT actually. The urinary symptom, fatigue, bone pain, this cardiac problems, flushings, and this we can see the darolutamide is not increasing the toxicity. Next slide. Actually, darolutamide, this is the actually now quality of life is very important actually. If you develop a new drug and quality of life, there are a lot of quality of the life scores actually. The PEC score actually. This is PEC prostate score actually, and if you see the PEC prostate scores, so this is actually physical, emotional, and cancer-related symptoms actually. That is increasing by 5.1 months. Next slide. This is the PEC score actually. They have a physical, emotional well-being, prostate cancer-related symptom, urinary symptoms, bowel symptoms. Actually, if you add darolutamide, the PEC scores actually better than only ADT. So the quality of life is much better with the patient than you only use ADT. Next slide. So the conclude actually, this is we will have a lot of patients who will not be eligible or want chemotherapy. So they without giving ADT, you have to decide in combining therapy, and you are go for the safest drug, that is darolutamide. So all the debaters previously actually there was no trial. The Saranath trial has proved that it is better or equivalent than other with other drugs with less safety concern. You can use multiple drugs this patient, and you can use darolutamide without being mainly following them very frequently. So, and the PEC score pen progression, which is typical of this trial, and it is increasing the time to pen progression, which is very important for the patient, and affect the social, functional well-being, sexually, urinary symptom, bladder symptom. So this is just if somebody is not using docetaxel, this is a standard of care. You is not only use IDT but use darolutamide. So this is the conclusion actually. So darolutamide is the will be one of the standard of care. Somebody can take that drug. Thank you.
Thank you, sir, for your nice presentation. And if any of audiences have any question, they can ask. So we'll wait for 1 minute so that you can have any question. So, sir, I don't think there are any questions. Thank you so much for your nice and elongated presentation. I thank both the speakers, Dr. P.N. Mahota sir, Dr. Shashanko sir, for their nice presentations and all the audiences who have joined in with us in today's meeting. And we can conclude, sir. So with your permission, we can conclude the meeting, sir.
Thank you. Thank you. Good night.
Thank you, sir. Good night. Good night to all. Take support.